Thank you very much. Appreciate it. Okay. All right. Well, that's I don't even need to give a talk. I'm out of here. That's I'm going to need a second before I say my first words, I think, actually. It's pretty touching, actually. So I'm already annoying the guys. They told me to stay I never stayed here. They want me to stand right here, but I move around a lot. So you might see me in the image sometimes. You might not see me in the image, but I'll roam around and look at you. So I am going to talk about aortic valve, aortic stenosis, but I'm going to back up actually, and I'm going to tell you there's a few slides you need to remember, and there's going to be a lot of fluff in the middle, and then some slides at the end I want you to remember, because ultimately I want you to take home some things that you can use to help treat but identify your patients with aortic valve disease. And I decided this year to focus just on aortic valve, not all four valves. But we're going to go back and figure out how we got to transcatheter therapies right now. How did we get to where we are? And then where are we going in the future here? So I do proctor for a lot of companies that make valves. Edwards is kind enough to be here today. I do proctor for them. But we're going to go through the history, and then it is kind of serendipity that I didn't know that Mo was going to say anything, so I already was going to plan to say a few things about him because he is a good friend, and John Laird is here too, and Reggie Lowe. So I put these three people up there because as I think about going through the history of valve disease and thinking about the history of my career, these are three clinicians that have been very much involved. Dr. Lowe giving me the opportunity to run the program at UC Davis when we first started. John Laird, both in Washington, D.C., where I was at Georgetown, he was at Hospital Center, and then out at UC Davis, really taught me how to just keep it simple. He's like, don't make procedures complex. Just keep it simple, stupid. He calls it the KISS technique, right? Just keep it simple, stupid. That's all you need to do. And Mo has been a huge, huge supporter of everything that I've done in valve disease and taking care of patients, both at UC Davis and up here. And there's no person who has brought his skills to the community of Shasta County than Dr. Khan up here. And you're here because he asked you to be here, and he's got a conference, and I think we're all here because of that. So I want to say thanks to all three of these people before I move on. So now we'll talk about aortic valve stenosis. All right, here's 2 or 3 slides you need to remember, then go do your sleep study. Go sleep for a little bit. He said you could take a nap. It'll be under an hour and a half. It'll be 40 minutes. Sleep and come back. So we know that the aortic valve, when it gets stenosed, you were either born with a congenital abnormality, a bicuspid valve, or you can have rheumatic fever, rheumatic heart disease, which causes this commissural fusion, or most of our patients have this age-related calcification of the aortic valve, age-related calcific AS, okay? That's what you got to remember. Remember that. Now, where can I hear this heart murmur is what you're going to remember next, okay? Okay, you can still hear the S2 closure sound. It's a loud murmur. Here's someone with worsening AS. It's kind of the same one, hang on. You can still hear the closure sound. You hear this large crescendo, decrescendo murmur. And then here's someone with it's very powerful. But a lot of times you can't hear the valve close. When it gets so stenotic, you can't hear it close. Right? So listening with the intent to hear something, right? Just because they don't come in your office with a known heart murmur or known heart disease, you got to listen with the intent to hear. I've told this before. One of the patients I take care of, a medical student was the one who told him that he had valve disease, right? He's an anesthesiologist coming in, and a medical student was examining him before he saw his doc. And the medical student told him he had aortic insufficiency, and he said, I've been coming to the doctor many years. I do not have AI. And the medical student picked it up, right? So he had 4+ aortic insufficiency when they sent him for an echo. So don't discount, your own ears when you listen, okay? The last slide you need to remember is probably this one, and then you can fall asleep a little bit. All right, get an ultrasound on your patient. Get an echocardiogram. Forget all these other things about how severe the valve is. If the valve area is less than even 1.5 on the aortic valve, just start getting your patients in to be seen. Let cardiologists take a look at them. We talk about velocities through the valve and gradients and all that stuff. If the valve area is less than 1.5, get your patient seen at that time. Because I'm going to tell you the treatment of aortic valve disease is going to rapidly progress here in the next years, and we're going to be treating patients much earlier than what we understand right now. Okay? We put together all these things about, is the squeeze of the heart okay? Is it not okay? How fast is the blood going through the valve? How high are the gradients? If the aortic valve area is less than 1.5, start getting your patients seen by a cardiologist. Okay? That's all you need to know. We'll figure out the rest of all this junk. Find the murmur, get the echo, and then get your patients seen. They might not need to be treated right away, but now they need to be followed, and they'll need to be treated soon. Okay? So the earliest descriptions of why valves become calcified were back in the 1600s, all right? The native aortic valve is actually an avascular structure. It has an outer layer of endothelial cells, which I'll show you, and then 3 layers of kind of these 3 inner layers. And it's about less than a millimeter thick, right? We have these vascular endothelial cells on either side. We have these interstitial cells, and they're all kind of held together, but it's just a thin sheet of tissue. So how does that actually become calcified? And ultimately, if we can figure this out, we might put Edwards and Medtronic and other companies out of business, but if we can actually stop the process of calcification, here's what happens. We get a breakdown in the endothelial layer. The blood gets inside that tissue, right? The blood gets inside the tissue. We get iron deposition as the cells break down. These vascular interstitial cells kind of go after these red blood cells. They start digesting them, and eventually they become these osteoblastic-like cells. They start making calcium or making bone as if they were in your bones. So they get turned into we call it this mesenchymal transformation. They start making calcium inside the leaflet itself. So if you could fix this process, you might prevent patients from getting non-rheumatic fever-related aortic stenosis. And the calcium builds up inside the leaflet, and then it can extrude and come through the top of the leaflets and eventually become these big furuncles and things like that that stick out the valve. But if we could stop the initial process, maybe we could stop the disease process altogether. Well, we're not doing a good job figuring it out because we haven't been able to do it. Patients are living longer, and the number of patients with aortic valve stenosis is going up just because patients are living longer. And we get that age-related calcific aortic valve stenosis. So if we think back, we're going to figure out how we got to the treatment of aortic valve stenosis, but we need to back way up. And Dr. Brunwald, who's been involved in the evaluation and treatment of patients with AS for a long time, had a historical perspective for doing this for over 60 years when he and Dr. Ross started their original research back in the 50s and 60s of patients with rheumatic fever who developed rheumatic aortic valve disease. They get commissural fusion and calcification. This is prior to left heart catheterization, and they didn't really have any great ways to treat aortic stenosis, right? Surgery was in its infancy. Endovascular therapies did not exist. Heart cath did not exist, let alone any other procedures beyond that. So the initial trials, the initial publications using commissurotomy, and I'm going to show you how the surgeons did this. They initially tried to figure out, and Dr. Bailey, you'll see, is one of the lead surgeons here, is how do we initially figure out what's going on, and then how do we fix it? Here's the initial descriptions, right? So they're just drawings, they're observations. When they would look at patients and their aortic valves, they could see what the valves look like. They tried to describe and draw pictures of what they looked like, how the commissures became fused. You could be born with a unicuspid or a bicuspid valve and what they look like. And if you read the original articles, there's not a lot of references. Like there's like 4 references at the end of the article because there's nothing else that was ever described about this. But they had to figure out a way to try and treat this. And they initially started putting things right through the left ventricle, which is interesting if we back up to the way that we first started doing transcatheter valves, which is through the left ventricle. But they would go through the left ventricle, and they would put these big commissurotomes to just break up rheumatic heart disease. They had these 3 little blades that they'd line up to the commissures, inflate them, try and break up all the calcification, and allow the valve to open and close again. But the mortality rate was very high, especially in patients with isolated AS that tend to have ventricular fibrillation if you touch or muck around with the ventricle. If patients had mitral stenosis as well, those ventricles seem to be a little bit more protected from some of the pathologic changes that take place, but the patients were dying of VF. So they even wrote in there that approaching the patients from a non-ventricular way is probably the way to go. We need to get out of the ventricle and come from up top. So they started to just sew things onto the aorta, putting their finger in there and breaking up the aortic valve with just their finger, trying to get in, get out without the patient dying, and going from there. And then they sewed on these little grafts so they could put their finger in, then kind of line up their little commiseratome again, and then inflate this thing in the valve and try and break it up. So that's how we started, very rudimentary, right? And it still had a very high mortality rate. Some of the early mortality rates for the ventricular approach were 17 to 20%. So, you had a 1 in 5 chance of dying from the procedure. So most people opted to die with their disease later on and not do the early surgeries. So he was, on the cover of Time. Underneath this, you'll see that there was, they did some cases, and then Dr. Brunwald and Dr. Moreau tried to develop some other ways endovascularly that we could assess and evaluate patients, because they were following all these patients now with rheumatic fever and rheumatic heart disease, but they needed ways to try and figure out the pressures in the heart, assess the severity of aortic valve stenosis. So they came up with this way that they could go through the venous system in the leg, come up to the right atrium, cross the interatrial septum, and go into the left atrium, and now assess patients with mitral stenosis. So I'm going to show you how they actually got to the left ventricle in these patients. We now can go through the radials or arms and go retrograde through the aortic valve into the left ventricle. But they came up with this way of doing transeptal left atrial puncture, and that's how we started it. Dr. Moreau, Ross, and Brunwald, right? So they took their little needles, they went over to the left atrium, they could measure pressures. Now you can see here that they have a left atrial pressure and a left ventricular pressure, and they're very excited that they could measure both at the same time. So how did they get the left ventricular pressure? We get so worried that when we're doing cases and things we're going to hurt somebody, they just shoved a needle through the chest wall into the left ventricle and hooked it up and said, okay, we got a pressure, right? We think about doing pericardiocentesis now and these other things, and we're so delicate, please don't touch anything. They just shove something right through the chest, hit the LV, and measured pressures. Right? You could do whatever you want back then, right? So their summary, pretty much, this is how I summarized their summary. They said, we did this, no one got hurt, it's pretty cool, let's do more stuff. Right? That was their whole summary there. So the 1968 paper from Dr. Brunwald, this is a graph that I'm going to show you that you'll see. This is the original paper that describes how they followed patients with rheumatic fever and rheumatic heart disease. And this is what we show, that you can go along with aortic valve stenosis for a very long period of time, but when you start to fall off the cliff and you start to have symptoms, you fall very quickly. Right? Dr. Laird showed you the mortality of patients with critical limb ischemia and how high it is at just a few years. Your chance of being alive at 5 years if you have severe AS with symptoms is worse than all of that, right? You have less than a 1 in 5 chance or 20% chance of being alive at 5 years if you don't do something about the valve. But medical management doesn't do anything for us. We can't give a patient any medicines right now. If we can figure out how to prevent the initial aortic stenosis events from taking place, maybe, but we haven't been able to figure that out now with any medical therapy or changes in what we do. But if you don't do anything for your patient, they pass away. So if you have your valve replaced, you'll do well. If you don't, you'll pass away. So medically treated symptomatic patients don't do well. Medically treated asymptomatic patients have problems. So remember, your patients should be seen at a center that could offer both surgery or transcatheter. That's the most recent guidelines or recommendations, that your patients should be seen at a center that can really offer everything for your patients. This is going to be hard to do because most centers still offer surgery, but not a transcatheter option. Okay? The more options we can give patients, the better we'll be. So we eventually got to doing surgical valves. We started with St. Jude, mechanical 2-leaflet valves. We got these ball valves. We made our way to porcine valves, and then we made it through the whole TAVR system. But we got there because a lot of patients were not getting surgery, right? They had too many comorbidities. They were not going to the operating room. And when we first started doing this, if even being over the age of 70 was too high risk, you were not going to the operating room. So Dr. Cribier kind of dedicated his life at that point to say, listen, we've got to have something else. Just because you're 70 and you have AS and you can't go to the operating room doesn't mean you should die from your disease. So he, back in 1985, tried to come up with a way to try and balloon or stretch the valve, which we're going to see here. It took a 72-year-old woman who had a significant gradient, so very high pressure in the left ventricle and a lower pressure in the aorta, and he's going to inflate a balloon inside that valve over a wire and see if he can stretch and break up some of the calcium. We had to have some therapy for this patient. She's only 72. So he gets it done, she does well, and now the medical community starts to pay attention because we might have something to offer these patients that's not surgery. The key, and Dr. Brunwald says, is listen, we didn't want to send people to surgery too early because they might die, and if we sent them too late, they weren't going to get better. So finding the sweet spot for risk was the big deal, and they knew they needed other options. So they started by inflating a balloon inside the valve, stretching it open, and trying getting the leaflets to move more freely. And they did multiple patients, right? And again, they jump right from let's do someone who's low risk to their third patient. The patient's older, they have a bad ejection fraction, all these other things. They jump right to a very serious, critically ill patient already on their third time they're thinking about doing this. So they use different size balloons, and they're getting success. They can inflate their balloons. The gradients are going down. Here's the left ventricle and the aortic pressure before, and then the left ventricle and the aortic pressure after. And the pressure in the left ventricle has dropped substantially. So the valve is opening a lot better right now, and we're relieving some of the pressure in the left ventricle. And patients started to do better. So more people started to catch on. So they started to do larger trials and larger databases with 400 and 500 people. And what they figured out was that the same thing we figured out now. If you're really too old and you have a bad ventricle, we've waited too long. If you already have heart failure, you're passing out, we've waited too long. How big we can make the valve after we do BAV has a lot, goes a long way for how well you'll do in the long run. So leaving that patient with less and less and less degrees of aortic stenosis, they did better over time. And he eventually put together conferences like this, right, where people could come and watch live BAV done for the first time. And this was the first live course. And he had all these people that showed up to try and figure out how to do this procedure because they wanted to take it home and do it where they're doing it. And again, it was at that point, it was the powers of observation, right? We had no randomized controlled clinical trials. It's how do I eloquently write down what I observed and what we did so other people can learn from it, right? Now, at this point, he figured out that the balloons would hold open all the leaflets. No matter how stiff the valve was, the balloon would hold it open. So could we come up with a way to keep those leaflets open, put a stent in there, and then he was going to figure it out from there. Could I stent it open and then, I don't know, can I do something else to give the patient a new valve? But that was his initial idea, right? Well, while he was still coming up with this, Henning Rudd Andersen, who's a Danish cardiologist, was at a meeting in Arizona in 1989. And he's listening to Julio Palmaz, one of the creators of the initial Palmaz stent, right? Who's affiliated with UC Davis and actually very good friends with Dr. Laird, if he hasn't escaped. So Dr. Laird knows the story of Julio Palmaz very well. But he's at this conference and he sees Dr. Palmaz talking about the stents and he says, "I can do this, right? I think I can do this for aortic valves." And he goes back to the butcher and gets a pig heart and takes the valve out. And then he molds the metal himself, right? He just goes down to the hardware store, gets metal, and he's just bending the metal into a frame, and then he sews this thing on it, and then he puts it into the aorta. He doesn't put it inside the valve of a pig, but he puts it in the aorta just to prove that you could do it with very rudimentary balloons and rudimentary devices, but he proved that you could actually do it. And then he does like 40 pigs, and he tries to put together a poster. No one comes to see his poster. He tries to publish it. All these people turn down his publications saying it's not worth it, it's not worth it, we're not even going to publish your data. And he gets eventually frustrated, right? And he can't keep doing what he's doing. And eventually Dr. Cribier sees this and goes, I want to buy your intellectual property. So he buys the intellectual property and the rights to try and develop this thing from the Danish cardiologist. So Dr. Cribier gets back involved, and he says, this is going to work. So he takes just stents, just some stents, and he puts them inside patients who have passed away, but fresh aortic valves, proving that putting a Pallmaz stent in there could hold open the leaflets. And he figured out that the ideal height of this frame could be about 14 to 16 millimeters because he didn't want to block off the coronary arteries, which sit right next to the aortic valve. He didn't want to interfere with the mitral valve next to it. And he figured out, well, what kind of metal should I use? How big should I make the frame? And is this thing going to stay? It'll stay right there when nothing's happening, but can I get it to stay when the heart's actually pumping? So it would take over 2 kilograms of force actually to pull out these initial stents that he put in. So he figured if it'll stay and it takes me really, really a lot of force to pull this thing out, it'll probably stay inside of a human. Probably. Right? But that's how he goes. He wasn't shoving anything through the chest wall at this point. So, I mean, what the heck? It seems like something feasible. So the search goes on, right? In 1995 to 99, no one wants to develop this concept. They say it's the stupidest thing they've ever heard, to Dr. Cribier himself. So he and Marty Leon and a couple of people start this percutaneous valve therapy company in 1999 in New Jersey. Not that long ago, right? 1999. A couple of engineers from Israel, and they gave them, they needed to create a valve that could be squished down, could be re-expanded, it needed to be small, it needed to go through a sheath, through a small vessel, to figure out how to do it. That's pretty much what they told the engineers. You got to figure out how to do this, right? And they went through a lot of iterations, and eventually these are the initial 4 that did it, with Dr. Leon on the left, Dr. Cribier, and the 2 engineers. And they came up with this valve design, right? They had to come up with the right material. How do they attach it? Is it going to be tri-leaflet? Is that the best thing? Should it be a 1 leaflet, 2 leaflets, 3 leaflets? What's going to decrease the stress the least? How strong can it be? How are we going to get it there? And they pretty much said, figure this out. You're the engineers. You figure out how we're going to do this. And they came up with a bunch of different valve designs and configurations. And you can imagine that the first thing you think of, probably not the thing you end up with. But they go through multiple iterations of these valves with different materials, trying to figure out what they could actually do that they could compress or re-expand a frame and put it in there so it would stay and be successful. Now again, sometimes you get lucky. So what had happened is that they didn't own the intellectual property to some of the certain valve techniques, right? They acquired it, okay? So Cribier had tried to, so I misspoke earlier, Cribier tried to get the intellectual property, couldn't get it. It was sold through a couple different companies. One of them turned out to be Hartport. Hartport got bought by Johnson & Johnson, which had a Cordis division that came out with a first drug-eluting stent. So Johnson & Johnson's going to buy Hartport. A couple of days before, 3 days before Hartport gets bought, Percutaneous Valve Technologies buys the valve portion of the intellectual property, but everything else goes over to Johnson & Johnson. But Johnson & Johnson could have owned the intellectual property for the valve itself, but 3 days earlier, it got sold to Dr. Cribier and Leon and their group. So they come up with a valve. They put this thing in a bunch of sheep. It seems to be working. They do multiple iterations, and then they say, okay, now what? Now what are we going to do? We think we have something that works. It has to go in the first human being at some point. Somebody has to do this. So they do their work, and now we're talking April 16th of 2002, right? We just passed the 20-year anniversary of the first ever valve that was placed. And they have a very sick patient that comes in. He's only 57. He's in intractable shock. He has a very low EF. He's very sick. He's on pressors. Cribier does the BAV. He balloons it the best he can. The patient's going to die at 57 from this valve disease. He's critically ill. He's had aortofemoral bypass. Their initial way to get up there was to go through the femoral artery. We're going to go around and put this valve in, right? That wasn't going to work. This patient has very bad legs. They can't get up the legs. So I want you to imagine this today. Like I walk in and say, hey, I've been developing this valve. I'm going to go through the leg. And then I tell you, oh, I'm not going to be able to go through the leg, and the patient's really sick, and I'm going to have to go through the interatrial septum and do all this other stuff and wrap the valve around. The hospital will be like, you're not doing any of this, right? You don't get to do this, right? But he talks them into letting them try this for the first time. And they have to go up through the inferior vena cava, poke a hole to the left atrium, go through the mitral valve, come out the left ventricle, come out the aortic valve to place this valve. And this is not how they designed it to go. And already their first case, they had to call an audible on the first case. Okay? So you can imagine what the other physicians, and I'll show you Helene Elcheninoff, who's one of the other physicians who did all the sheep work, and she's coming up shortly. She gets left out of a lot of these things, though, but I think Dr. Cribier has done a good job always pulling her up to the podium to say, hey, she deserves as much credit as anybody else. So you can imagine what the look on your face is going to be when you do this for the first time, right? These are the real pictures for the first case when they're positioning the valve. Because in their mind going, this is either going to make or break. It's either going to work or not work, right? For the first time you do something, there is no one to rely on. You're the most experienced. They had done 100 sheep. That's all you got. There's no one else to talk to. No one else has done it, right? So this becomes successful. April 16, 2002, the guy gets off pressors. The valve stays. And of course, when you're in France, you can have champagne at any time. So you just, right? You have champagne. This is just a few days after. Few days after, a guy at 57 who was going to die of intractable shock from AS is off pressors and having champagne and leaves the hospital, right? And they knew right there, if they could do it in the sickest patient, they could make it work in others. So then from there, we go through history, right? 3 more patients are done. The best money ever spent, right? Not $44 billion to buy Twitter, but $125 million. Edwards buys the technology for $125 million, right? That is the best money ever spent to buy a technology. I can tell you that right now because it's changed the way that we treat patients right now, right? So it was best return on your investment ever. They developed multiple valves. Medtronic comes in with core valve. Now we're off and running, right? They created an initial valve that were 23 and 26 millimeters. They developed a new balloon system. And now we do randomized trials. Now we do randomized trials where we take high-risk patients. We randomize them. The initial trials were patients who could not have surgery at all. So those patients had no option. Those patients did much better with a valve than medical therapy. We know that. So a lot of high-risk patients were done. And it gets FDA approval in 2011 for non-surgical extreme risk patients, okay? And I won't go through all the trials, but the valve continues to get better and better and better. So this particular valve now is in its 4th iteration. Every time we came up with a problem, they fixed it. A new problem, they fixed it. So it used to be the stroke rate was high. Now it's very, very, very low. The pacemaker rate used to be high. Now it's very, very, very low. The valve would have leak around it, but now they've created all these different skirts, and now the leak rates are extremely low, right? The stroke rate is less than surgery. The pacer rate matches surgery. The complications, the vascular complications are much less. AFib rates are much less, and the valve areas are big. So we've come up with a way now to compete, really. And that's how we got to low-risk trials, right? We shouldn't be taking low-risk patients and subjecting them to something that hasn't been perfected. So you had to get through the extreme risk, the high risk, the moderate risk patients. You better really know what you're doing because now you're going to low-risk patients. Because these low-risk patients had an option. They could have surgery. They're low risk for a reason. So now we had to randomize these technologies in low-risk patients. And people did well. The best thing that will come out of these low-risk trials, again, just published in 2019, and you could see that, patients did better early on in the first year with a transcatheter valve than surgery. They had less risk of dying or stroke or complication rates within the first year. Mortality was less, right? And these are, again, in the best surgical centers, right? This is not being done in someone's backyard or my garage. If you're in this trial, you're the best surgical centers that we have to offer. So this is as good as the data can look, right? Durability is going to come into play and lots of things that we'll talk about. And then self-expanding. Dr. Potman and his team did the same thing with the Medtronic valve as well, showing that transcatheter valves in low-risk patients can be done safely. The key for all these is we're going to follow these patients for 10 years. 2 things are going to come out of it. Valve durability. right? The question I get asked every day is, how long will the transcatheter valves last? We haven't seen any breakdown in these valves so far early on at all. What we are seeing, which may be a surprise to some people, is that the surgical valves might actually break down faster than the transcatheter valves. If that does happen, then our surgeons are on the wrong side of this equation all the way around, right? They're banking on durability of their valves. The thing is that they have never followed their patients, every single one of their patients, for 10 years to figure out what happens. Most surgeons will tell you that that valve lasts 15 years. When we do our transcatheter valves, we can put them inside a surgical valve. The average age of that valve is 7 years. So the average age of the valves, when we put our TAVR valves inside the surgical valve, that surgical valve has been in 7 years and is already failing. So we don't have the data that we need to say these surgical valves last a long time, but we're about to get it. One valve might last longer than the other, but we're going to see. The key I'll tell you in going forward is we currently are missing the boat, right? We're waiting way too long to get our patients a heart valve, right? We don't wait till our patients are on dialysis, blind, and missing a leg to treat their diabetes. We don't wait till you're in a skilled nursing facility post-stroke to treat your blood pressure. And if you got 4 flat tires and your rims are bent, you think about putting air in it, right? We are waiting way too long. We're waiting for people to have symptoms and problems. And I'm going to show you that's way too long. We're going to be replacing valves much earlier for patients. Here's moderate aortic stenosis, patients with moderate aortic stenosis, which is why I told you if your valve area is less than 1.5, send them to a cardiologist, because we're eventually going to get to this area. We have trials going on right now treating patients with moderate AS first. This is patients with moderate AS. And what you're going to see is that how well do these patients do? The bottom 2 curves, the purple and black curves, are patients with severe AS and moderate AS. And how well are you still alive? So if we follow these patients over time, whether they had valve replacement or not, the moderate and severe AS patients are almost superimposable. So clearly we're missing the boat, right? We're missing the boat on when to replace these valves. So we could ask, well, my patient has severe aortic valve stenosis, but they have no symptoms. We should be able to watch them, which is the current practice in the US and in the world right now. We treat symptomatic severe AS, not asymptomatic. If your patients are not having symptoms, we don't treat them. It's going to change, right? Because we have new insights as to what's actually going on in the heart and how damaging this is to the heart. By the time we eventually do the valve, we clearly have let it gone on too far. So the previous guidelines were based on surgical options, and we were really hesitant to send someone to the operating room unless they really needed it, because valves don't last forever unless you put in mechanical valves, which require Coumadin. They last very, very long time, okay? So first of all, we weren't doing a good job figuring out who has symptoms, so we were waiting too long to send people. How do we define symptoms in a 75, 80, 85-year-old patient who just thinks, I'm getting older, I'm slowing down. I shouldn't be able to do the things I did last year because I'm 1 year older, right? So we should be putting patients on low-level treadmills, right? If you want to freak out anyone who's running your treadmills, bring someone with severe AS and put them on a treadmill and tell them, all right, I'm going to walk over here. Thanks for treadmilling my patient, right? Because they get very nervous that you're going to exercise someone with severe AS and they might pass out or fall over right there. But that's what we should be doing, and that's what the guidelines say, that we should be putting these patients on a low-level treadmill to see how they do. Are they truly asymptomatic? In the future, I'm going to tell you it's not going to matter. Here's asymptomatic severe AS patients that get valve replaced and don't get their valve replaced. Remember that they're asymptomatic. So if you're dying that quickly, that sounds like you're not asymptomatic. At least your heart's not asymptomatic. Something's happening, right? I don't know, maybe it's all REM sleep. I learned that was bad. Maybe it's that, I don't know. But maybe it's trazodone. I can't do that. But clearly we got to do something. So this is not asymptomatic. If you're dying this quickly, something's wrong, okay? We're finding out that not every patient progresses the same. Some patients, their aortic valve gets worse very quickly. Every 6 months to a year, it's really narrowing down. The velocities are going up through the valve's getting tighter. And that we know that in these particular patients, if you are a rapid progressor, you do worse. Right? You want to have mild to moderate AS. mild to moderate AS, and have slow progression, you do well. Even if you have mild to moderate AS, but you progress quickly, you're not going to do that well. We have to start following these patients much more closely and getting their valve replaced much earlier. So following progression, staging aortic valve stenosis, I'm going to show you, becomes very important. And they've come up with some new staging kind of guidelines. It's really just cardiology based right now that we do it. We haven't kind of put this out there, but we know that if we look at patients and look at the heart and see where they are, if we catch someone early on and the heart is completely normal, we know they're doing well. Some of them then get LV hypertrophy. You can go on to mitral regurgitation. You can go on to then affecting the right side of the heart. If we wait till we have LV hypertrophy, mitral regurgitation, pulmonary hypertension, right-sided heart failure, and then think we're going to send them to surgery and they're going to do well, we're kidding ourselves. The highest curves up here are waiting to stage 4, 3, 2, and 1 to get valve replacement, and this is the number of people that die. So even if we try and treat you, the later we wait to treat you, because maybe you just develop symptoms, the heart still doesn't do well in follow-up. We've already waited way too long. The damage is not reversible, which is what we're hoping it would be at the time of surgery. We want to cause LV regression, and we want that LV to still be happy. Right? This is the same curve. The longer we wait to do something, then when we do it, you don't do as well after. So we are not getting to patients early enough, and I guarantee you the guidelines are going to change. The initial partner studies, right? Patients that had severe aortic valve stenosis, high-risk patients, if we backtracked and look at that data and apply this staging system, we could see that even when we did TAVR on patients, the patients that had healthier hearts did much better later on. And the patients that we waited for all these things to happen did much worse in follow-up. So we can apply this data to patients that we've already operated on or done TAVR on and know that we are waiting too long to do this for patients. Yes, they get through the procedure, but how are they doing at year 2 or year 3 or year 5? And if they're going to die at year 5 because we didn't get to them early enough, we need to back up our way of thinking, right? So there's some simpler classification schemes that are out there now, just trying to see where patients are from stage 0 to stage 4. We're going to start using these things. We're going to start using MRIs. We're going to start using biomarkers, BNP, and there's some other soluble markers I could tell you about that we're going to start following. And we're going to be taking care of patients much earlier when we see any signs of stress on the heart than waiting for something bad to happen and then do it. Again, these patients, these particular authors put together and looked at their group of patients, and every time they do this, it's the same thing. If you wait too long, your patients don't do well even at 1 year. And the upper left-hand corner is the chance of you being alive. So if 24% of your patients who you said, hey, we're still going to do TAVR on them, are dead at a year, but if I would have caught them down below, 96% of the patients are alive, right? If we get to you when you don't have LV thickening and mitral valve disease and pulmonary disease and right ventricular disease, you're going to live a lot longer. But you might not have symptoms at that stage. So we have to get to you a lot earlier, right? And looking at this as a trial that was just completed, and the data we'll have very soon. We have some surgical data now that suggests taking patients with severe aortic valve stenosis before they have symptoms, patients do better. Waiting to get those patients surgery, they do not do well. This was a trial that Edwards completed over 1,000 patients that had severe aortic valve disease, and we were lucky enough to participate in it. They don't have symptoms. That's what they tell you. They don't have symptoms. We don't trust patients, right? Because they're worried, because if they have symptoms, they know you're going to do something to them, right? So they don't want to tell you they have symptoms. So they had to go on a treadmill. We had to put them on a treadmill and see how they did on the treadmill. If they passed their treadmill, no symptoms, did everything, we called them asymptomatic. Now you can be part of the trial. If you had symptoms, we had them get their valve done. So you have no symptoms, now you're randomized to watch and wait until you have symptoms, or we're still getting your valve replaced now by transcatheter means. So you had a TAVR valve, or you waited till you had symptoms, and then you had your valve done. And that trial is complete now. We're going to see how these patients did. Some of the patients who are asymptomatic still have not got their valve done, and we're following along, waiting for symptoms. The key will be how many people that we waited on died, had heart failure, got admitted for lots of things, progressed to these different stages, stage 2, stage 3, stage 4, while we wait for them to have symptoms, and how are they going to do long term? So we'll have some preliminary data very soon, but what we really care about, I think, is what's going to be the data we have in 4 or 5 years after the trial, and how are these patients doing, okay? So, we need to be more vigilant about listening for any heart murmurs. I focused on AS today, but mitral regurgitation, aortic insufficiency. We have treatment for these modalities right now. We have to be more vigilant about listening. We need to act much sooner. Even as a cardiovascular community, we're going to have to begin acting sooner. And I can tell you that that's where we're headed. There's no question that's where we're headed, in treating patients way sooner than what we do right now. Medical therapy so far doesn't help, but if we can figure out how to stop the initiation of aortic valve stenosis, we're going to be fine. But I tell you, listen with the intent to hear something. If you find a murmur, you can help save that patient's life. I guarantee it. Okay? So, as Dr. Khan said, I've been lucky enough to come up and do transcatheter valves up here in Reading at Shasta Regional Medical Center, and it's been I think a fantastic experience. I probably get more out of it than anyone else, and I'll tell you that honestly, that patients are very thankful that they don't have to go even 2 or 3 hours further than Reading. Reading is the big city, right? They're coming here to get it done here, but they're not going any further. The patients do very well. It's been very rewarding, I think, for us. A lot of the people that work in the cath lab, that do echo, that do screening, are here today. Becky's here. Sam's over there. Sam always gives me a nice picture of the gallbladder for some reason when we're doing the case. I don't know, but we have to keep him focused. He wanders on me sometimes. Watch him. But, these people work very, very hard to make sure that the people up here get treated appropriately, quickly, and they do an extremely good job. So I will tell you that the program up here is very, very well put together. And the people that work to make it happen, Jessica Dukes, our valve coordinator, we decided to send her on an expense-paid trip to Florida for 2 weeks. I mean, we didn't pay the expenses, she is, but we sent her for 2 weeks. So she's not here today, but the group up here is very well put together. I thank them for allowing me to still come up and do some of these things. We're training physicians now. Azib Khan is here. I saw him earlier. He's floating around on me somewhere. He's up here now doing cases, so we're training people how to do it. People in the community that are here on a daily basis are learning how to do it, and it's really, really going to help things moving forward as we go forward. So I'll end with just the last slide. These are the first 2 patients that we ever treated. They knew we had never done the procedure before, and they let us do it to them about 10, 11 years ago, and I'll always thank them because they gave us our first shot. So thank you very much.
Thank you, Jeff.